Laboratory Values Part 2. This is Martha Olson from Iowa Lakes Community College. We left off looking at the nomogram and the blood clotting. We will move now into the serum electrolytes, also called lights. We see sodium, potassium, calcium, magnesium, phosphorus, and chloride as the main ones that you need to focus on for this unit. The lab values are listed there, and let's talk about each one and see if we can figure out why they are so important to know these lab values. Sodium is a major cation in the extracellular space. When you eat a lot of sodium-rich food, you might notice that you have a little bit of swelling or edema the next day. That's because sodium pulls water with it into that space, causing you to look and feel kind of puffy. It's regulated by aldosterone and antidiuretic hormone, and water and sodium, like I said, go together. So sodium levels are between 136 and 145 milliequivalents per liter. Potassium is very important. 3.5 to 5 milliequivalents per liter is the normal value for potassium. It's a major cation inside the cell or intracellular. The big part about potassium is it regulates your heart rhythm. People that come in with a low potassium get admitted on telemetry, and we also administer potassium IV to get the level up. As you remember from nutrition, potassium is never given IV push because you can kill a person. We dilute potassium and give it over several hours in a diluted IV. The serum concentration is fairly small, so minor changes can have huge impact on a patient's health condition, their heart rate, some of the other things. We know that potassium is excreted by the kidneys, so your patients on diuretics, on furosemide and Bumex can be impacted with this electrolyte because potassium gets eliminated along with all the fluid with that diuretic. It's balanced out by aldosterone, sodium reabsorption, and your acid-base balance. So there's a lot of things that go into the potassium for this electrolyte. Calcium is important to know because it's mostly in bones and intracellular, but there is some found in blood and in active forms. Only ionized calcium is active, and as I said, most of it's in bones, but one of the things that calcium, when we look at it as an electrolyte, is if your blood level is higher, it can be an early indication or help us to maybe start thinking about bone cancer, because with bone cancer, the tumor growing in there can displace calcium and cause the calcium to go into the blood, and with a higher blood level, oftentimes that can be the case for metastasis. We know that calcium is very important for excitability of nerves and muscle, for muscle contraction, and so a lot of your athletes will really try to watch their calcium level for that muscle contraction. Magnesium 1.3 to 2.1. It's an extracellular fluid, not very much, but mostly, again, bones and intracellular, just like your calcium, and it has to do with neuromuscular junction and also a coenzyme or cofactor for numerous enzymes. Phosphorus 3 to 4.5 milligrams per deciliter. Higher levels are intracellular. There is that inverse relationship with calcium. If you look on a can of pop, your calcium is very low and your phosphorus is high in many of your soda pops. And what happens is the phosphorus displaces or pulls the calcium out of the bone, goes into the bone, and you have a loss of strong bones from the loss of calcium, contributing to osteoporosis. That's why limiting the amount of soda becomes important. Phosphorus is needed for the making of energy, or ATP, and cellular metabolism. So as you can see, electrolytes are very important for many body functions. Chloride is the last one we'll talk about. Its level is 95 to 105 milliequivalents per liter. It has to do with the electrical neutrality in the body, and chlorides typically follows sodium. If you look at a bag of fluid, it will be called sodium chloride, and they go together. Hyperchloremia is high chloride in the blood. EMIA is the suffix meaning in the blood. And hypochloremia then is low. Very rarely occurs when you have this, but that would be the terms if you would have that happen. Your patient with diarrhea, very dehydrated. They're losing electrolytes from the vomiting because your stomach makes acids, and that has to do with balancing out, keeping homeostasis, and also with diarrhea. You lose a lot of electrolytes from that loose stool, and it's very concerning, especially to your vulnerable population like the infant. 3 or 4 diarrhea stools can sometimes get a small child admitted to the hospital for fluid replacement as well as electrolyte replacement. We see things like Pedialyte that have electrolytes in them that sometimes a person at home might use to replace some of those electrolytes. Looking at the nutrition impact, or part of this fasting blood sugar is 70 to 110. They've lowered that in recent years. They want a tighter, better blood sugar control for a person for better outcomes. And then your glycosylated hemoglobin is done in percent. About a 4 or 5 to 7% is where we want a person's A1C, is how it's often termed. Your fasting blood sugar is what your blood sugar is right now at this moment. And so you can do it before a meal, and it's a true fasting blood sugar. If you would do it an hour after eating, it's not going to be accurate because it's not fasting. Glycosylated hemoglobin tells about the overall average blood sugar for the last 3 months. And we look at a red blood cell with a 120-day lifespan. We see how much sugar is attached to that, and that's how a glycosylated or A1C level is obtained. Each percentage that it goes higher tells about the average blood sugar for a diabetic or a person without good blood sugar control. Each percentage higher tells about how much further out of control they are. Your patient with diabetes, then, fasting blood sugar tells that current blood sugar. We usually get that with a finger stick, or we call it point of care testing, where the nurse, or in some facilities even the CNA, is allowed to poke the finger, get a blood sample, run it through the little machine, and then we dock or download that information to the lab. We use that fasting blood sugar to be able to tell about if we need to give insulin, if they're on a sliding scale insulin, and if the blood sugar is higher than 110, sometimes your patient will get a little bit of regular or short-acting insulin. And then the glycosylated hemoglobin is oftentimes done in the clinic, so the doctor can kind of know on an average where the blood sugar has been for the last several months for that patient. Also important to know is our liver function tests. There's 4 here that we're going to highlight: albumin, ammonia, the bilirubin, and the total protein. Albumin is a protein. It's made up of muscles, enzymes, hormones. It helps transport oxygen, drugs, hormones, and enzymes in the body. So looking at an albumin level is important. It's a very large protein, and if you have albumin spilling out into the urine, that's very concerning for kidney damage. It helps with the oncotic pressure. So if you don't have a very healthy albumin or a low albumin level, you can see edema, and it's because the pressure has allowed that fluid to leak into the interstitial spaces. So it helps keep the volume in the vessel where it's needed to maintain the blood pressure. Albumin transports a lot of things in the blood. It's kind of like the taxi service in the blood. Drugs, lipids, hormones, and toxins are bound to albumin, and they circulate in the blood, go to the liver, where then they get out of the taxi or detach from the albumin, and they are converted in the liver then to something more water soluble so the kidneys can excrete them. Albumin also has a relationship with calcium levels, which we'll be talking about a little more. So remember, albumin is found in the liver or made in the liver, and with a diet that is low in meat and other things that contribute to a low albumin level, we will see that starting to affect the patient. Excuse me. A patient with burns, we know that the albumin has a half-life of about 12 to 18 days. So I can fast for 12 to 18 days and my albumin is probably going to be okay. It's when you get past that 12 to 18 days that typically you will start then seeing the edema and the other complications that go along with low albumin. Your patient with burns, they're going to lose a lot of albumin out of those burns, and they will need more albumin in the diet to help heal the tissues and help heal those burns. The body will break down muscle to get the amino acids it needs for making serum albumin. And so you may not see that albumin level drop very quickly with malnutrition until, like I said, after about 18 days. It will decrease faster if a patient is very critically ill. So if you're working in a high-level ICU with burn patients, you may see that albumin drop quicker than what is anticipated. Ammonia, 35 to 65 is your normal range. It's a byproduct of protein metabolism, and where I mostly see the ammonia looked at very seriously is your patient on dialysis. Because they only go to dialysis 3 times a week, that ammonia is toxic. It's traveling around in the blood, causing a lot of burning and tissue damage until they go to dialysis and they get that ammonia cleaned out. So typically your patient that is on dialysis will have a limited diet of protein, especially on day 1 and day 2, before they go to have their dialysis or their blood cleaned. We know that the liver makes the urea, it's excreted in the kidneys, and so it's very easy to become toxic with this. I've seen it for a patient with liver failure. They had a very high ammonia level, and that ammonia caused a lot of confusion. The patient was very unsafe and did not want to stay in bed because of the damage from that ammonia. We think of ammonia when you open a can or a bottle of ammonia that you might have in your cupboard at Burns. That's what the ammonia in the body is doing to the tissues as well, causing a lot of damage. The total bilirubin is 0.0 to 1.5 milligrams per deciliter. We want the patient to fast before the test because any fat in the diet that we know fat takes longer to eliminate from the bloodstream will interfere with the bilirubin. And the total bilirubin is looking at both indirect and direct bilirubin. The red blood cells are broken down when they get to be 120 days old and they die, and so the bilirubin is a waste product of a red blood cell, and as the spleen starts, cleaning out and doing its thing, we see the free bilirubin carried to the liver then by your protein albumin. Because it's lipid soluble, it's made into a water soluble product and is excreted then, hopefully, by the kidneys in the urine. Your total protein is another test that is important to know for this unit. When we look at a total protein, 6 to 8 grams per deciliter. There's 2 kinds or classes of proteins that we have. We have albumin and globulin. Proteins are important for our cells and tissues, and they, again, help with the oncotic pressure. And the globulins are our immune system, very important for that. So we use this total protein test to look for nutritional problems, kidney and liver disease. The UA is the last thing we'll talk about, and as we look at the UA, most of the things should be negative. We should not have glucose, red blood cells, white blood cells, albumin, ketones in a UA. We collect a UA with a midstream or a sterile cath. Specific gravity tells us about the density of urine compared with water, and so the higher the number, we know the more concentrated and perhaps the more dehydrated a person is. The pH can depend on diet. We know that meat and eggs make the urine more acidic, and if you're more of a fruit and vegetable eater, it is going to be more alkaline. Sorry about that. With our elimination, the BUN is 10 to 20 milligrams per deciliter. The amount of nitrogen or waste product that's in the blood, and that urea then is again from that protein metabolism. We have creatinine. Male and female rates are listed here. They're very, very close. We know that creatinine is a better test to tell us about how healthy the kidney is and the ability of that kidney to eliminate waste. Creatinine is not affected by hydration status, so it's a very good test to help us know about the overall health of the kidney. Glomerular filtration rate is 90 to 120 milliliters per minute. Again, it tells how well the kidneys are working based off of that creatinine level. Patient in renal failure, then we look at the BUN to creatinine ratio, and it should be about a 1 to 10 or 10 to 1 healthy ratio. For creatinine to, or BUN to creatinine, but that can change depending on what else is going on in the body. When we look at the SED rate, we know the SED rate has to do with inflammation.